There is a result sitting in your medical records right now, a number your doctor looked at, nodded at, and moved past, that almost certainly does not tell the whole story about your kidneys. Your eGFR was fine. Your creatinine was normal. And so the visit moved on. And maybe you moved on too, but there is a second test, a urine test, not a blood test, that a large study published just this year found was detecting kidney damage in nearly 11 out of every 100 adults whose eGFR was still in the normal range, 11 out of 100, sitting there with a clean blood result. And kidney damage already underway, showing up only in the urine. That test almost certainly was not ordered at your last visit. Before we go any further, one thing first. Do not stop any kidney medication based on what you hear in this video. Do not skip a dose. Do not change anything about your treatment based on this alone. What we are doing here is learning something specific so you can have a better conversation at your next appointment. That is the only goal. Now, if you have a copy of your last kidney lab results, go get them. If not, picture the number, the eGFR, the creatinine. Hold it in your mind, because by the end of this, you will know exactly what that number can and cannot tell you, and what the second number, the one you probably haven't had, actually measures. Your eGFR came back normal, and that result may have told your doctor almost nothing about whether your kidneys are actually being damaged right now. A team of investigators led by Dr. Sanchez Ospina and colleagues published their findings in the Clinical Kidney Journal in April 2025. They screened 9,890 adults through primary care. Among the patients whose eGFR was still above 60, the number that keeps most people in the "you're fine" category, 10.88% had chronic kidney disease that only appeared when a urine test was added to the blood test. Nearly 1 in 9 people. Walking around with a normal-looking eGFR and kidney disease the blood panel couldn't see. That study was conducted in Spain, and its findings are observational, which means it describes what was found in a screened population, not a controlled experiment. But what it found is consistent with what the International Kidney Guideline has been saying since 2024, that the urine albumin test and the eGFR belong together on the same panel for anyone at risk. One of them is routinely ordered. The other almost never is. Here is where you are right now. You are in one of two situations, and from where you are sitting, there is no way to know which one. The first situation, your eGFR is genuinely reassuring. Your kidneys are filtering at a healthy rate. The blood result was the right test. It showed what it was supposed to show, and the number you saw reflects what is actually happening inside your kidneys. Your doctor was correct to move past it. You are fine. The second situation, your eGFR looks normal because the earliest sign of kidney damage does not show up in your blood. It shows up in your urine, specifically as albumin, a protein that your kidney filters are built to keep out of the urine, but that begins slipping through when those filters start to fray. The damage can be months or years underway. The blood result doesn't see it. Not because the blood test is broken, but because it is measuring the wrong thing at the wrong stage, and the urine test that would have caught it was never ordered. You are in one of those two situations right now. The only way to know which one is to have the right test. And by the end of this hour, you will know what that test is called, what it actually measures, how it works, why it wasn't ordered, and the exact words to say to get it documented at your next visit. Let's start with what happened the last time you got those normal results. By the end of this hour, here is what you will know. You will know what the urine albumin-to-creatinine ratio, the uACR, actually measures, and why it is a fundamentally different instrument from the eGFR. Not a better test or a worse test, a different test, looking at a different part of the kidney's job. You will know how the mechanism works, what is happening inside the filter when albumin starts appearing in your urine, and why it appears there before the overall filtering score has any reason to change. You will know why this test is not on the standard panel at most primary care practices in the United States, despite the fact that the International Kidney Guideline, updated in 2024, specifically recommends it for anyone at risk. You will understand the gap between what the guideline says and what the EMR prints on your lab order. And you will understand why that gap exists without being angry at your doctor, because the reason is structural, not careless. You will know the exact sentence to say at your next appointment to ask for it, not a general request. The specific words in an order that works. You will know the 3 possible responses your doctor might give, and what to say next in each case. And you will know the one sentence that gets all of it documented in your chart, so that what you asked and what was decided travels with your record to every appointment after this one. One thing before we go further, do not stop any kidney medication based on this video. Do not skip a dose. Do not change your diet or your treatment plan based on what you learn here without speaking with your care team first. What you are learning here is for one purpose, a better conversation at your next appointment. That is the whole point. If you have your last lab results nearby, find the EGFR line. If not, picture the number. We are going to talk about exactly what that number is and what it is not. You sat in a chair or you got a call and a number came back. And the number looked fine. And whoever delivered it moved on to the next thing because that is how the visit works. A result in the normal range gets a sentence, maybe 2, and then the conversation turns to something else. Blood pressure, medications, whether you had been keeping up with the other things on the list and you left or you hung up. And for a day or 2, maybe longer, you felt the specific relief of a result that didn't require action. The number was fine, the doctor wasn't worried, you didn't need to be either, but somewhere in the days after, the question came back. The one you didn't quite ask because you didn't have the language for it yet. Something about whether one number on a blood panel is really the whole picture, whether normal for your stage is actually an answer, or whether it's a shorthand that leaves something out, whether there's a test you haven't had. You may have searched, you may have found the phrase kidney function test and gotten a list of blood markers you'd already had. You may have found the word proteinuria and not been sure what it meant for you or whether it applied or whether it was something your doctor would have mentioned if it mattered. Here is what you didn't find, probably because it's the kind of thing that doesn't show up easily in a search. The urine test that your kidneys international governing guideline says belongs on the panel with your EGFR is not on most primary care lab panels in the United States. Not because anyone decided you didn't need it, because the default panel was built before the evidence was this clear, and panels don't update automatically when guidelines do. By the end of this hour, you will have the words. There are 3 kinds of people who are watching this right now, and all 3 of them have a reason to be here. The first is someone who is newly in this. A result came back recently that changed something. Maybe a creatinine that edged up, an EGFR that came in lower than expected, or a doctor who said we should keep an eye on your kidney numbers, and then didn't explain what that meant. You left with a number and not much else. You are searching now because the number is sitting in the back of your mind, and you need it to mean something specific, not just something vague and unresolvable. What you need to know is whether there is a test that gives a clearer picture, and whether it is something you can actually ask for. It is, and it is. The second is someone who has been managing this for a while. You track your EGFR. You may have changed your diet, started a medication, started following your labs more closely, and your numbers, by the blood test, have been holding, stable or close to it. But something has been quietly bothering you. The feeling that the picture you are managing is incomplete, that there is a dimension your blood panel doesn't capture. You are not wrong. There is. And the reason your doctor hasn't led with it is not because they don't know about it. It is because the system that prints your lab order doesn't include it by default, and a 12-minute visit does not always create the moment to add it. The third is someone who is skeptical, maybe skeptical of the medical system in general, maybe skeptical of this particular type of content, maybe just the kind of person who wants to see the research before they change anything. You are not going to be told to take a supplement or join a program or trust a claim that sounds too clean. You are going to be given one specific study, one guideline document, and one mechanism, and you will evaluate it yourself. That is the right way to do this. No matter which of those 3 you are, what sits underneath this topic is the same: a specific biological fact about how the kidney filter fails, and the fact that it makes one test show damage before another test can. That's where we start. The test is called the Urine Albumin-to-Creatinine Ratio, the uACR, And the most important thing to understand about it, before anything else, is what it measures that a blood test does not. Your eGFR, estimated glomerular filtration rate, is a measure of how well your kidneys are filtering your blood overall. It is calculated from a substance in your blood called creatinine, which is a waste product your muscles produce. The kidneys clear creatinine out of the blood, and the rate at which they clear it gives an estimate of how much filtering capacity is still working. When that capacity drops below certain thresholds, the eGFR number falls. That is how kidney disease is staged by blood test, by how much filtering power is left. The uACR measures something different. It measures what is getting through the filter that shouldn't be. Here is the distinction that matters. Your kidney filter is built with extremely fine holes, fine enough to keep large molecules, including proteins, on the blood side. One of those proteins is albumin. Albumin is a protein your liver makes. It circulates in your blood, carrying hormones and nutrients and waste products throughout the body. It is too large to pass through a healthy kidney filter. A healthy filter keeps it in the blood where it belongs. When the filter starts to fray, when the fine mesh of the glomerulus, which is the technical name for the filtering structure inside each nephron, begins to degrade, albumin starts slipping through. It appears in the urine, not in large amounts at first, but measurably. The uACR test catches that slip by measuring how much albumin is in a single urine sample relative to the creatinine in the same sample. The creatinine in the urine acts as a reference point, adjusting for how concentrated the urine is, so the ratio gives a stable, reproducible number regardless of how much water you drank before the test. A uACR below 30 milligrams per gram of creatinine is considered in the normal range, classified as A1. Between 30 and 300 milligrams per gram is moderately increased, classified as A2. Above 300 is severely increased, classified as A3. Those categories carry real clinical meaning, and we will come back to what they mean for your risk and your management. But first, the finding that this video is built around. A team of investigators, including Dr. Sanchez Ospina and colleagues, published a study in the Clinical Kidney Journal in April 2025, the ONDAAS study, which screened 9,890 adults through primary care. The researchers were specifically asking what happened when urine albumin testing was added to the standard eGFR panel for adults at risk of kidney disease. What they found was this: 10.88% of the adults in their screened population, people whose eGFR was still above 60, meaning they were not in the kidney disease range by blood test alone, had chronic kidney disease detected only by the urine albumin result. Their eGFR said no kidney disease. Their urine said otherwise. To be precise about the study, it was observational, conducted in Spain, and it describes a screened primary care population rather than a controlled experiment. The ONDAAS findings are consistent with, and in fact align directly with, what the international kidney community has embedded in formal clinical guidance. But the study itself does not prove causation. It identifies what was found when both tests were run together. The finding that matters: a substantial fraction of adults who would have received a clean bill of kidney health from a blood panel alone had kidney damage that only a urine test could see. That is not a small number, nearly 1 in 9 screened adults. And that finding carries a second layer. Once the urine albumin result was added to the eGFR staging for the CKD patients in the sample, 35.57% of them were reclassified into a higher risk category than the blood test alone had placed them in. Their stage was worse than their eGFR suggested. The full picture, using both tests, was more serious than the blood-only picture, for more than a third of the CKD patients in the study. There is also a separate thread of evidence about what the uACR number means for your future, beyond just detecting damage. A meta-analysis, a pooled analysis of 41 randomized controlled trials, found that a 30% reduction in uACR was associated with a 27% lower risk of reaching kidney failure. The uACR is not just a flag. It is a number that moves in response to treatment, and moving it appears to change where you end up. That is the anchor device at the center of this video. The proteinuria early signal, Protein leaks before the filtering score falls, and the urine test catches the leak. Albumin in your urine is the smoke alarm. The eGFR is the structural survey. It tells you how much of the building is still standing. The smoke alarm goes off earlier, but most routine lab panels only run the structural survey. Now, one thing to say clearly before we go further. The presence of albumin in urine is not the same as a diagnosis, and a uACR result needs to be interpreted alongside your eGFR, your history, your medications, and your other numbers by a clinician who knows your case. A single elevated uACR can occur for reasons unrelated to chronic kidney disease: intense exercise, a fever, a urinary tract infection, uncontrolled blood pressure on the day of the test. The KDIGO 2024 guideline specifies that a doubling of the uACR on a subsequent test warrants further evaluation, meaning one elevated result is a reason to look more carefully, not a conclusion in itself. This video is not a diagnosis. It is a reason to have a conversation. Do not change any medication or treatment plan based on what you hear here. Bring what you learn to your care team. The goal is a better appointment, not a self-diagnosis. The question in your head right now is probably how this actually works inside the kidney. How does a filter that still has enough functioning capacity to produce a normal eGFR start leaking protein at the same time? The mechanism is more specific than the general description suggests, and once you understand it, you will know why the urine test catches what the blood test cannot, and why that matters at every stage. Picture a coffee filter, not a paper one, something finer. A mesh so tight that only very small molecules can pass through. The liquid comes through, the grounds stay behind. Your kidneys have approximately 1 million of these filters, and the technical name for each one is a glomerulus, which is the filtering structure at the top of each nephron, the individual functional unit of the kidney. Through these filters, your blood is processed around 180 liters of blood fluid per day. The waste products and extra water pass through into the tubule, which is the tube below the filter, and from there they become urine. The proteins, including albumin, stay in the blood because the mesh is too fine for them to get through. That is how it works when everything is intact. Now consider what happens when the mesh starts to fray. Not uniformly. Kidney disease does not damage every filter at the same rate. It tends to affect some filters more than others, in patches, depending on the cause of the damage and the individual's biology. Some filters are intact, some are damaged, some have already been lost entirely. The overall filtering rate, the eGFR, reflects the sum of all of them. If you have lost some filters but the survivors are compensating, the overall rate stays in a normal range. The blood test sees the average. It doesn't see the fraying. But the fraying shows up somewhere else. When the mesh in a damaged filter enlarges, when the gaps in the glomerular barrier widen, albumin, which under normal conditions can't fit through, starts to pass. It crosses into the tubule. It ends up in the urine. And it does this before the overall filtering rate has fallen enough to change the eGFR number, which is why the uACR is an earlier signal. It is measuring the damage to the mesh, not the total number of filters still running. This is the mechanism that some of the foundational science of kidney disease describes as the dual nature of proteinuria. Albumin in the urine is a marker of filter damage, but it is also, at the same time, a driver of further damage. Here is why. Albumin is not supposed to be in the tubule. When it passes through a frayed filter and enters the tubule, it does not just move harmlessly through. As it travels down the tubule, it triggers an inflammatory response in the tubule wall. The cells lining the tubule react to the presence of a protein that isn't supposed to be there, and that reaction causes scarring. The technical term for that scarring is tubulointerstitial fibrosis. In plain terms, the smoke from the fraying filter irritates the walls it passes through, and over time that irritation leaves permanent damage. The alarm going off is also slowly damaging the hallway it sounds in. This is why reducing albumin in the urine, not just detecting it but bringing it down, is a treatment target, not just a monitoring number. A 30% reduction in uACR is associated in the evidence with a meaningful reduction in the risk of reaching kidney failure. Quieting the alarm also reduces the damage the alarm is causing. Now here's the piece that is specific to your age and your stage, and it matters. The glomerular barrier, that fine mesh, and is not static. It is maintained by a layer of specialized cells called podocytes, which wrap around the outside of the filter and help hold its structure together. Podocytes are slow to regenerate once damaged. With age, and with the conditions that tend to accompany kidney risk in your age group, elevated blood pressure, blood sugar that has run high, years of low-grade inflammation, podocyte health degrades more quickly than in a younger person. The damage to the mesh is more likely to accumulate and less likely to reverse, which means the window in which the uACR is your early warning, the window before the eGFR has registered the damage, is exactly the window that matters most. Not later. Now. There is one more layer to this mechanism that almost no general practice visit covers, because the connection sits across two different bodies of literature. Albumin in the urine is not the same as all protein in the urine. Proteinuria, the broader term, includes many proteins. Albuminuria specifically means albumin, and the reason the uACR test focuses on albumin is that albumin is the most sensitive early indicator of glomerular damage. Other proteins appear later, when the damage is more advanced. Albumin appears first. It is the specific molecule that crosses earliest through a fraying glomerular barrier, which is why a test that measures it specifically gives an earlier signal than a test looking at total protein in the urine. This distinction matters for a practical reason. If you have ever had a general urinalysis and the routine urine dip test that checks color, clarity, and the presence of various substances, and the result came back normal, that test is not the same as a uACR. The standard urinalysis dipstick is designed to detect larger amounts of protein, at levels typically seen in more advanced kidney disease. It can miss the early moderate albumin leaks that the uACR catches. A normal urinalysis does not tell you that your uACR is normal. Now find your last lab result if you have it. Look for the eGFR line. Write down the number or hold it in your mind. That number is your structural survey, how much filtering capacity is currently measured as functioning. Now look for a line that says uACR or urine albumin or albumin/creatinine ratio or microalbumin. If you cannot find one, that is the finding. It was not ordered. That is not a criticism of anyone. It is a description of how the default lab panel is built. And that gap is exactly where the next part of this story begins. The question in your head right now is probably, if this test is this important and the guideline says to order it, why wasn't it on my panel? The answer is not what you expect, and it is not a comfortable one, but it is a useful one. Why hasn't your own doctor mentioned this? It is the obvious question. If the International Kidney Guideline, the one that governs how nephrologists and primary care physicians are supposed to approach kidney disease monitoring globally, specifically recommends ordering a urine albumin test alongside the eGFR for anyone at risk, and if that recommendation has been in successive versions of that guideline for over a decade, then why is the test absent from most routine lab panels in the United States? Why did you get a normal results letter that was based entirely on a blood test? The answer is not what most people expect. It is not that your doctor doesn't know about the uACR. It is not that there is information being withheld. The answer is structural. And once you see the structure, the gap makes complete sense, even if it remains frustrating. Here is how the standard visit works. Your primary care physician has, on average, between 15 and 20 minutes per appointment. In that window, they are managing every active problem on your chart. Blood pressure, medications, diabetes management if applicable, preventive screening, the thing you mentioned at the door that wasn't on the original agenda. Kidney function in a patient whose eGFR is in a stable range is typically a one-line item. The result came back. It is within expected parameters. Moving on. The visit is not built for depth on any single item unless the number is alarming. A normal eGFR is, by design, not alarming. The lab panel that gets ordered at your annual visit is typically a standing order, a default set of tests that the electronic medical record generates automatically based on your age, your diagnoses, and your insurance coverage. That panel was configured in most primary care practices based on standard of care norms that predate the current evidence on uACR. Panels do not update automatically when guidelines do. Someone has to go into the system and add the test. At the practice level, that requires a decision by a physician, an administrator, or a quality improvement committee. It requires a workflow change. It requires everyone in the practice to be briefed, and it requires that the change happen for every patient at risk, not just the ones who happen to mention it. That is the lag, not ignorance, not negligence. A system that runs on pattern-based defaults, and a guideline that updated faster than the defaults have. The KDIGO 2024 CKD Clinical Practice Guideline, the 2024 update of the International Standard for Kidney Disease Management, includes a specific practice point: test people at risk for CKD using both urine albumin measurement and eGFR assessment. That language has existed in KDIGO guidance in various forms since the 2012 guideline. The 2024 update reinforces it. The research supporting it, including the ONDAAS findings published in April 2025, continues to accumulate. The guideline and the research are aligned. The practice panel has not caught up. It is worth saying this clearly because it is easy to read this situation as a failure of individual care. Your doctor is not the problem. A nephrologist who sees your full panel, eGFR plus uACR plus the rest of your kidney markers, would almost certainly have ordered both. The issue is that many people at risk for kidney disease are not yet seeing a nephrologist. They are in primary care with a 15-minute visit and a standing lab order that reflects 2012 practice norms rather than 2024 guideline language. And nothing in that system creates a prompt for the patient to ask about the second test, because nothing in that system tells the patient the second test exists. The uACR tends to be ordered more consistently in patients who have already been diagnosed with kidney disease, particularly those who are already in nephrology care, or those whose eGFR has already crossed into a stage that triggers closer monitoring. For patients in the earlier stages, G1, G2, even early G3, whose blood tests have been stable, the uACR is most often absent, which means the test is being skipped in the exact population where it would be most useful. The people with normal or near normal eGFR, in whom early damage is the only thing the urine test can catch, because the blood test has nothing to report yet. You are, in many cases, in that population. A normal eGFR, a stable creatinine. No one has told you the second test exists, because the result that would have prompted the conversation, an abnormal eGFR, hasn't happened yet. The system is waiting for the fire before it sends the alarm, but the alarm is supposed to come first. The only way the pattern updates for you specifically, before the lab panel catches up, before the default order is changed, is if someone brings the request into the room. That someone is you. And what you need next is precise. The words, the sequence, and a path through each possible response your doctor might give. Let's start with what you are actually asking for. The test is the urine albumin-to-creatinine ratio. Say it as uACR. Some practices may list it as a microalbumin urine test, or as a spot urine albumin test, or as a urine albumin-to-creatinine ratio. All of these refer to the same measurement. It is a single urine sample, a spot sample, meaning not a timed collection, not a 24-hour urine, and it is run in a standard laboratory. No special preparation is typically required. Many insurance plans cover it with a diagnosis code for diabetes or hypertension, both of which are among the most common drivers of kidney risk in this age group. If you are unsure about coverage, your doctor's office can check before the order is placed. You may also want to ask at the same appointment whether a repeat confirmation is appropriate if the first result comes back elevated, because the KDIGO 2024 guideline notes that a doubling of the uACR on a follow-up test is what warrants further evaluation. One elevated result opens the question. A confirmed elevated result answers it. Now, the opening sentence. Not a paragraph. One sentence. The sentence is this: I've been reading about the urine albumin-to-creatinine ratio test, and I'd like to understand whether I've had one and whether it's something we should add to my routine monitoring. That is it. You are not asking the doctor to diagnose you. You are not challenging the adequacy of your prior care. You are expressing that you have read something specific, that it raised a question, and that you want to understand your own situation relative to it. That is a completely reasonable request from any engaged patient. The doctor does not need to agree with your interpretation of the evidence to order a test you are specifically asking about. There are three responses you may get. The first, the doctor orders it without question, explains where it fits in your monitoring, and the appointment moves forward. This is the most common response when the request is made clearly and without confrontation. The test is inexpensive, low burden, and guideline supported. Most clinicians who know their patient is asking specifically about a named test with a specific reason will order it. The second, the doctor says they are familiar with it, notes a reason it may or may not be indicated for your specific situation. Perhaps you have already had one. Perhaps there is a specific clinical reason it is being deferred, and offers an explanation. This is also a good outcome. You are in a conversation, you have information you didn't have before the visit. Ask them to walk you through where your uACR history stands, if you've had one previously, or to explain the clinical reasoning if they are recommending against it. You do not need to win this exchange. You need to understand your own record. The third, the doctor says they don't think it's necessary or moves past the request without engaging it fully. If this happens, you have two options. The first is to ask one follow-up question, calmly, without confrontation. Is there something in my history that makes you confident the uACR isn't needed? That question invites a clinical explanation. It is not a challenge. It is a request for information. The second option is to note the request for yourself and raise it again at your next visit, or to request a nephrology referral and raise it there. You are not required to resolve this in a single appointment. What you do not do in any of these scenarios, you do not argue. You do not cite the study as evidence that your doctor is wrong. You do not threaten to switch providers. You are not in the exam room to win a debate. You are there to get a question into the conversation and into the chart. After the conversation about the uACR and whatever direction it goes, there is one more sentence. This is the sentence that matters for every appointment, not just this one. It documents what happened in the room, and it travels with your record. The sentence is this: would you be comfortable noting in my chart that I asked about the uACR today and what we decided, so it's part of my ongoing record? That is the keystone, not because it changes the outcome of today's visit, because it changes the outcome of every visit after this one. A note in your chart that you asked about a specific test and that a clinical decision was made about it, to order it, to defer it, to confirm it had already been done, means that the next clinician who opens your record sees a patient who is engaged, who has done specific reading, and who is tracking their own monitoring. It also means that if the test is deferred today and your situation changes in 6 months, the question is already in the record. You don't start from zero. A word about what may happen if your uACR comes back elevated. The result will be a number, milligrams of albumin per gram of creatinine. Below 30 is A1, considered normal to mildly increased. Between 30 and 300 is A2, moderately increased. Above 300 is A3, severely increased. These are not diagnoses. They are staging categories that, combined with your eGFR, determine your CKD risk category under the International Classification System. An A2 result in a patient with an eGFR above 60 places, that patient in a risk category that warrants monitoring and, in many cases, intervention, including consideration of medications that have been shown to reduce albumin leak and slow progression. Those medications are a conversation for you and your care team. This is not the place to name a specific drug as the right answer for your situation. What it is the place to say is this: if your uACR comes back elevated, the appropriate next step is not to search online for what it means and make a decision from there. The appropriate next step is to bring the number to a clinician who knows your full picture and can tell you what it means in your specific context: your eGFR, your blood pressure, your other medications, your history. That conversation is the one you are now equipped to have. You have the research, you have the mechanism, you have the question, you have the words. Do not stop, start, or change any kidney medication based on this. Do not skip a dose. If your uACR result raises a question about your medications, route that question through your doctor or kidney team. What you are doing by having this conversation is not self-treating. It is self-advocating. Those are not the same thing. Now step back for a moment. Picture this. You are at your next appointment. You walk in with your last lab result. The eGFR number you know by heart now, the number you understand as a structural survey, a count of remaining filtering capacity. You have one question prepared, one specific question with a specific test name attached to it, and a sentence ready for when the conversation ends. The doctor opens your chart. The visit starts the same way it always starts. Results reviewed, blood pressure checked, medications confirmed. And then you say the sentence. You have been reading about the urine albumin-to-creatinine ratio, and you would like to understand whether you have had one and whether it belongs in your monitoring going forward. The doctor looks up, not because the question is alarming, because it is specific, because you have named a test, given a reason, and framed it as a question about your own record. The conversation that follows is different from the visit you have had before, not longer necessarily, different, because you brought something into the room that the room was not going to generate on its own. At the end of the appointment, you ask for the chart note. Would they be comfortable noting that you asked about the uACR today and what was decided? They say yes, most will, and it goes into the record. And now your chart says something it didn't say before, that you asked a specific question on a specific date, and that a clinical decision was made. That note travels with you to the next appointment, to the specialist, if you see one, to any provider who opens that record and reads the history of your care. That is the first future. Now picture the second one. You are at a family dinner or on a phone call, a sibling, an adult child, a friend who mentioned in passing that their doctor told them their kidney numbers were fine. And you ask, did they check the urine test too or just the blood? And they don't know. And you tell them, not as a lecture, not as alarm, but as someone who did the reading and found the question worth asking, that there are two tests, that they measure different things, and that one of them is often not ordered unless someone specifically asks. You do not tell them what to do. You tell them what you know. And the conversation they have at their next appointment starts from a different place than it would have if you hadn't said anything. That is the second future. The identity you are stepping into is simple. It is the person who monitors two numbers, not one, who understands that the blood result and the urine result are not the same story, who walks into every future appointment knowing which of those two tests is in their record, and who will ask the right question when one of them is missing, who, at the family dinner or the phone call, is the person who has done the reading and knows the right question to pass on. That skill is not specific to this test. It is specific to the habit of knowing what your panel contains and what it doesn't. The uACR is one example. There are others. Other markers that belong in the monitoring of kidney disease at your stage, that are guideline recommended, that are absent from many default panels, that require a specific ask. The habit of knowing which tests you have had and which you haven't, and having the words to close the gap, is portable. It works for every number on the panel, every appointment, every year going forward. You are not just managing a diagnosis, you are managing information. And the person who manages their information well, consistently over years, is the person whose slope holds, whose numbers get caught early if they move, whose doctor opens the chart and sees a record of someone paying attention. What is a uACR test, and do I need one? The uACR, Urine Albumin-to-Creatinine Ratio, measures how much albumin, a protein that healthy kidneys keep in the blood, is leaking into your urine. It is a single-spot urine sample, and it catches early kidney filter damage before the overall filtering score changes. Whether you need one depends on your risk factors: diabetes, high blood pressure, a family history of kidney disease, or an eGFR that has been flagged even once are all reasons the test belongs in your monitoring. The KDIGO 2024 International Kidney Guideline recommends ordering both the uACR and the eGFR together for anyone at risk. If you have not had a uACR, the question to ask your doctor is whether this should be part of your routine panel. My eGFR is normal. Can I still have kidney disease? Yes, and this is the central fact all of this is built around. A large study published in the Clinical Kidney Journal in April 2025 found that among nearly 10,000 screened adults with an eGFR still above 60, nearly 11% had chronic kidney disease detected only by urine albumin testing. The eGFR measures how much filtering capacity is functioning. The uACR measures whether the filter is leaking protein it should be retaining. These are different measurements. A normal eGFR and a normal uACR together are genuinely reassuring. A normal eGFR and a missing uACR leaves the picture incomplete. What does it mean if my uACR is high? A uACR between 30 and 300 milligrams per gram of creatinine is categorized as moderately increased, a 2. Above 300 is severely increased, a 3. An elevated uACR means your kidney filters are allowing more albumin through than they should, which is a sign of filter damage and also, in itself, a driver of further damage. One elevated result is a reason for a follow-up test. The KDIGO guideline notes that a confirmed doubling warrants further evaluation. An elevated uACR combined with your eGFR result places you in a specific risk category that your care team can use to plan monitoring and, if appropriate, discuss treatment. Do not change any medication or treatment based on a uACR result alone. Bring the number to your doctor and ask what it means for your specific situation and your specific medications. Why didn't my doctor order this test? The most honest answer is the default lab panel at most primary care practices in the United States does not include the uACR, even though the International Kidney Guideline recommends it for at-risk patients. The panel reflects standing orders that predate the current evidence, not a decision by your individual doctor to withhold a test. The gap is between guideline and practice default, not between what your doctor knows and what you need. Everything you have been reading here exists to close that gap by giving you the specific words to ask for the test directly. Your doctor is not the obstacle. The default panel is, and default panels change one request at a time. What is your angle? See, why are you telling me this? There is no supplement, program, or product attached to this. The uACR is an inexpensive, widely available, guideline-recommended test that costs little to order and requires nothing beyond a standard urine sample. The reason to lay this out is to translate what the research says, including what the research says about gaps between guidelines and standard practice, into language that allows you to have a better appointment. The uACR is one of the clearest examples of a guideline gap that a single question in the exam room can close. No angle beyond that. The uACR story is one instance of a structural pattern that runs across kidney care, and, more broadly, across the management of chronic conditions in primary care. Guidelines update. Practice defaults lag. The gap between them is not filled automatically. It is not filled by the 15-minute visit. It is not filled by the standing lab order. It is filled one patient at a time by the person in the exam room who has done specific reading and brought a specific question. The uACR is today's example, but the pattern extends. There are other markers in kidney disease that are guideline recommended, absent from many default panels, and accessible through a specific ask. Each of these has a version of the same story: a research finding, a guideline update, a practice default that hasn't caught up, and a gap that a specific ask can close. The skill you are actually practicing is not ask for a uACR. The skill is know what your panel contains, know what the guideline says it should contain, and have the habit of closing the distance between those two things at every visit. That skill scales. It works if you are newly flagged. It works if you have been stable for years. It works in primary care and in nephrology. It is the skill of the patient who monitors information, not just symptoms. And it is the skill that gives the clinician something to work with. You didn't get here by being careless. You got here by paying attention. And now you have one more number worth paying attention to. The next time you have labs drawn, you will look at the panel differently, not with more fear and with more precision. You will know which test is there and which one isn't. You will know what the one that's there can tell you and what it cannot. And if the second one is missing, you will have the words to ask for it. That is the difference between managing a number and managing your kidney health.